Welcome to the Advances in Research and Innovation stream at SNOMED CT Expo 2025. Thank you to Daedalus for sponsoring this stream. My name is Nick Egerhaus, and I'm the Global Vendor Engagement Lead and Customer Relations Executive for the Middle East, Africa, and North America at SNOMED International. I'll be your moderator for today's session. We'll address all questions at the end of this presentation, and for our online audience, please use the Q&A button to submit your questions to the presenter. For those attending in person, feel free to use the microphone provided in the room when the time comes. It's now my pleasure to introduce Robert Vander Stichele from Ghent University, Faculty of Medicine, who will be presenting a combined presentation. SNOClass, a Belgian terminology project for mapping relevant SNOMED CT concepts to WHO family of classifications in 3 domains, and selecting relevant SNOMED CT concepts to consider for a mapping to 3 classifications using hierarchy semantic tags. Robert, over to you.
Good afternoon, everybody. Well, I'm happy to see a good turnout in the forest room of the conference at the last session. I hope this will be a little bit like the biblical wedding of Cana, that the wine is served at the end. You'll be the judge of that after this presentation. Both speakers, we prepared that the presenters have no conflict of interest. Joseph Roumier is not here. I will present both presentations in one piece for 20 minutes, and then we have 10 minutes of questions. So the overview is that we'll start with a problem statement and making the aim of the project explicit, then present the project team, have a small introduction on mapping, from what are we mapping to what, describe the 3 classifications, and then give a glimpse of the methodological approach and preliminary results of each of these 3 projects, and then end with a time frame for further work. The problem statement. Every investigation starts with a problem, said Karl Popper. And here our problem statement is, how can SNOMED CT be implemented with the support of clinicians by respecting the existence of classifications in their relevant domains? If you want them to accept SNOMED, they have to know what will happen to their own classification. And the aim of this project is to explore the appropriate way to map a reference terminology, SNOMED, to 3 specific domain classifications. ICPC3, which is the general practice classification, ICI, the International Classification of Health Interventions for interventionists and surgeons, and ICF, International Classification of Functioning for occupational therapists. And to provide a significant sample of matched SNOMED concepts for each of the 3 domains in a standardized format, so that we can start to check whether the methodology is appropriate, and then estimate the effort to complete the task. The project team is from Ghent University, and for ICPC, it's the Unit of Primary Care and the WHO Collaborating Center for Primary Care that work on this. For health interventions, the Unit of Medical Informatics, and for international classification, the Research Unit for Occupational Therapy. And the 3 teams work together in this mapping process and learn from each other. That's interesting. And there's a coordination by me and Joseph Roumier, who is the IT and semantic web support, and very important for our project. So first, the introduction to the mapping approach. Directionality in mapping is really important. We map from SNOMED to classifications. SNOMED International, 370,000 concepts, to classification ICF, 1,500 codes, ICPC3, 1,600 codes, and ICI, a little over 5,000 if you only look at interventions on body systems and functions. We map between conceptual systems, between the reference terminology, SNOMED, and the classifications. ICF is specifically for functioning, ICI for interventions, and ICPC3 is also something that covers primary care, so everything. general practice, just like SNOMED has the intention to cover everything. It's important to note that these maps are language independent. They are maps between conceptual systems and hence language independent. A small sketch of differences between a reference terminology and a classification. SNOMED is the reference terminology for clinical practice. It's comprehensive, over 370,000 medical concepts. It is poly-hierarchic. It has a strong ontological structure, complex one. And the classification is much smaller. There is mutual exclusiveness and exhaustiveness. There can be ragbacks. It's a simple taxonomic structure where you have a class, a stem code, that is the box where a number of concepts will be collected, and that is defined also by inclusion terms. But a two-level hierarchy, which is relatively simple in the case of ICHI, a three-axial system. Let's go to a description of the three classifications. ICPC 3 has 14 chapters representing the localization of problems and diseases on a body or a body system. Most of these chapters are divided in two components, a symptom component and a disease component. The S stands for symptoms, complaints and abnormal findings, and the D for diagnosis and diseases. And it is built also to capture not only the diagnosis, but also the reason for encounter, the subjective and objective examinations, the assessment, and the plan for interventions. And it's a very simple thing. It can be printed on 4 pages or on the desk of the doctor, but it has this computer version. And here you see for the an example for the respiratory system, a very simple symptom, cough, without further specification, and then a diagnosis, pneumonia, without further specification. So very broad categories. The ICF classification for functioning focus on activities, eating, sleeping, walking, swimming, doing sport. And these activities are modulated by, they are linked to body functions and structures, of course, to health conditions, to environmental factors and personal factors, but also to participation, meaning that for each activity, the assessment is made whether the patient can do it, which is capacity, and whether the patient really does it, which is performance. And that it's really meant to assess the functional status of patients. And it has its own linearization, which is common with the linearization of the HUFIC family of international classifications, to which also ICD-11 belongs. They have this common foundational components, and that move up their linearization. You see it's a quite simple taxonomic relationship. ICHI, here we have put an example of the intervention classification. The example is appendicectomy. It has appearance, it has inclusion criteria, index terms, and in the end, the intervention will be classified along 3 axes. The target, that's the appendix, the action, that's the excision, and the means going through a cut in the abdomen. It's hence a 3-axial system. And it has also its own linearization, ending in this 3 axis, common to the WHO FIC family of classifications with ICD-11. So our mapping approach, it's a bit of a complex slide, but I try to walk you through. It's about the taxonomy of valid matching from SNOMED to classifications, each of the 3. And on the left, you see the complex hierarchy of SNOMED, which can be several layers deep and evolves from a high level of aggregation and low granularity to a low level of aggregation and high granularity. And on the right, you see the classification, which is simpler, much simpler, a stem code with inclusion terms. And if we want to bring on the relationships, we are really looking for the exact matches. These are the hooks by which we enter the one system to the other. And the exact matches can either be with a stem code or with an inclusion term. And above that and below, you have the broader to narrow match and the narrow to broader matches. And because SNOMED is so enormously big and the classifications are small, depending on at what level of aggregation the classification will bind, we will have a lot of SNOMED codes that bind with a stem code, mostly narrow to broad. For instance, for the GPs, it will be, the matches will be at a very high level of aggregation, while for ICI, which is specific interventions, it will be at the bottom of the level of aggregation, and so much more close to each other. The first selection of the relevant SNOMED codes for each classification is by choosing per domain the relevant semantic tags, and experts of the 3 domains selected from the 19 semantic tags the relevant tags for each domain. Just a note that semantic tags have no definition, and they were conceived originally to alleviate ambiguity for concepts with an identical label. So if you start from the 370,000 active SNOMED concepts, for ICI, you use procedure and regimen and therapy, you bring it down to 60,000 SNOMED codes that are potential targets. If you do that for ICF, it's much more broad and flu, and it's not really very helpful. It's only a small reduction, and the same is true for ICPC3. So this approach shows a little bit what the extent of the work will be, but is not really helpful to start working. And therefore, we further selected relevant SNOMED concept per domain by choosing a core sample for this project. And for ICPC3, we choose the Belgium, we choose 4,160 SNOMED concepts that came out of a previous project. The coupling of thesaurus in general practice to SNOMED. For ICF, we work with the UK ref set of activity of daily living, and that's about 1,000 concepts. And for ICI, with the National Library of Medicine, ICD-9-CM procedure codes that were mapped to SNOMED, and that's a starting point of 2,500, which is feasible for a small project in a limited time. So the methodology for classification of each of the methodology for mapping for each of the classifications and its results. This is a picture of this resource that exists in Belgium, the Belgian bilingual biclassified thesaurus. It's a huge collection, lexical collection of over 500,000 lexical entries, often used in general practice, and in French and in the Netherlands, in Dutch. And from these 500,000, 50,000 are paired lexical entries, meaning that we have a label in French and in Dutch that has the same meaning and that is connected to an identifier. And this identifier in turn is connected to 2 coding systems, ICD-10 and ICPC2, the previous version of ICPC. And we use that for 20 years already in Belgium to construct longitudinal, valid epidemiological research. And from this resource, we selected 11,000 often used, frequently used terms, and started to match them to SNOMED. And we managed to do so for with a result of 4,160 SNOMED concepts that are matched to that resource. And because we have in this resource a map to ICPC2, we can use the existing ICPC2 map to ICPC3 to provide candidates for mapping between SNOMED concept and ICPC3. And we have, for each of these 4,160 codes, we have between 1 to 5 candidates of ICPC3 classes. And that needs to be chosen and validated, which will be the right one. But the choice is already restricted by this system. In addition, there is a complex semantic work to be done to align it, to navigate the two hierarchies, which can be very complex. And as an example, we have in both systems here post-traumatic stress disorder, which in SNOMED has 4 children: acute, chronic, complex, and delayed stress disorder. Post-traumatic stress disorder has an equivalent in ICPC3, and there's there's an exclusion criteria that's called complex post-traumatic disorder. That is an exact match with one of the children of SNOMED, and the others are narrow to broad maps to concept. And this is a very tedious work that needs to be done, but if you do that code by code for ICPC3, you end up with, per code, with between 20 and 100 SNOMED codes that are correctly mapped, a few exact matches, and most of them narrow to broad. For the ICF methodology, we started from the UK Activities of Daily Living, 1000 core set. First tried out several approaches of mapping, the classical ways, the string search, the fuzzy search, business rules, even tried AI, but all that didn't work very well, because we need to acknowledge that mapping from SNOMED to ICF is not straightforward. SNOMED often pre-coordinates its functionality concepts, while ICF has activities that are modulated by qualifiers like capacity and performance, and that's not always easy to map. And therefore, preparatory work was needed to parse the pre-coordinated SNOMED functionality concepts in activities and capacity and performance qualifiers. And this allowed to solve more or less the alignment of most of the ADL SNOMED scores with ICF. I give you an example. The SNOMED codes does not ride a bicycle, difficulty performing gardening, difficulty walking. You need to parse that if you want to link that to ICF into does not, has difficulty performing, able with difficulty in relation to walk, gardening, and ride a bicycle. And if you want the details, they're on an e-poster here in the conference. Then we come to ICHI, where it was, which is bigger than the two others, but on the other hand, very much more closer to SNOMED at the low level, only interventions, and at a great level of specificity, both in SNOMED and ICHI. We could start with, we used Whoosh Python library, which is a lexical matching program in Python. You start with exact lexical string matches, you expand it with fuzzy matches at decreasing probability of match. We use AND approaches and OR approaches for multi-component terms, and we set a lower limit of probability score to exclude unlikely matches, so that the human validation, the manual checking by human expert, was not too tedious. Here is an overview of the source and target site per domain. You see the 370,000 concept of SNOMED. The core set from which we started, For GPs, 4,000. For the functioning, 1,000. For EG, 2,500. For ICPC3, which is the most difficult one, we are only started to work with a few codes of the ICPC3, which already resulted in 200 SNOMED matched codes. And this will now quickly evolve, I think. For ICF, 128 exact matches were found. So still a big deal to go. And for the EG, 570 matches at stem code level, plus exact matches at 712 inclusions. So that was really a substantial linking already between the two systems. The output of these three mapping projects will be compatible with the simple standard for sharing ontological mappings, the SSSOM proposal. You see the reference in the slide. It identifies the subject ID, the source, the object ID, the target, the predicate, which is the relationship, and then a justification. What was the method used? What was eventually the confidence score for the map? Whether was it a lexical match or a manual creation? The provenance, where does the mapping come from? Who contributed to it? What was the creation date? All kinds of metadata. And it's a standardized way of reporting mappings. So to end, we come at the time frame of the SNOClass project results. This year was an upstart year. We started in January, basically developed a methodology during this year and are now working on the first exemplary core sets to be matched. And then in 2026, we would like to continue, progress, automate as much as possible, and estimate the effort. These are the three people, the bunch of people that do the job. And it's really interesting that we do this together, that these three mapping projects exchange their approaches, their mistakes, their errors, their trial and errors, and learn from each other. And so it's really good to work together on this. And this is the website where we put our deliverables and results. So thank you for your attention.
We will now begin the question period. As a reminder, if you're in the room, please use the microphone to ask your questions so that everyone can hear clearly.
Well, I'll leave it like this.
Just take it.
Yeah.
You just take it. Yeah.
There we go. Okay, thank you for this interesting talk. It shows what I also realized, that it's complicated to map.
Yeah.
It's not a straightforward process. And the one thing that I always fear is you do all this work, and then 2 months later, SNOMED comes with new codes. 2 months later, again and again and again. How do you maintain such a complicated process?
Yeah. I think that's the answer, but well, medicine evolves, of course, over the years, and new codes and new concepts are needed. So you need to be ready, and you need to have a maintenance plan. At this stage, we are creating the map. It's a little bit early to think about a maintenance plan, but we will have to, at some point we'll have to, and much depends on what aspects that we can automate and what we can learn about automation during this trial and error process.
Thank you.
Anyone else in the room? I'll chip in a question. Why is the level of aggregation important for the mapping?
Well, I think that's the originality of our work, that we consider level of aggregation. That if you look at the SNOMED map, that there has to be matched, that you look where it is in the hierarchy. At the high level, at the low level. And how complex the hierarchy beneath is there. For the GP classes, we will be in the very high aggregation, for the EG levels in the very low ones. And level of aggregation is something that is mostly ignored in mapping projects. We are trying to take it into account. You can calculate for each SNOMED code how many levels are up and how many levels are down. That can be done automatically. That's why we have our semantic web expert to do that for us. So we have a clear numeric idea of this level of aggregation, and it helps us to select codes and to navigate the hierarchy.
Great. Anyone else in the room? Okay, thank you, Robert, for an excellent presentation. With that, we conclude this block of sessions and SNOMED CT Expo 2025. Don't forget to catch up on all the sessions you missed on Zoom events, and we hope to see you next year in Sydney, Australia for SNOMED CT Expo 2026. Thank you.